the purpose of the conference is to see if the specific PCR phage test could show Borrelia miyamotoi more realistic prevalence here in Europe and in some also US. This test, the PCR test is based on the viruses that infect bacteria. One of the characteristics of these viruses, they are not sensitive to antibiotics. And this will be very helpful in the future because we will be able to use them even if the people are under antibiotic treatments. So I cannot resist to, sorry, go back there. I don't know, yes, it's working. And I'll show you how the bacteriophages are acting.
Signal is sent through the long tail fibers to the base plate. This unravels the short tail fibers that bind irreversibly to the E. coli cell surface.
This is an E. coli example.
The base plate changes conformation and the tail sheet contracts,
for all the bacteriophages.
At the end of the tail tube to puncture the outer membrane of the cell. The lysosome domain of GP5 is activated and degrades the periplasmic peptidoglycan layer. The remaining part of the membrane is degraded, and DNA from the head of the phage can travel through the tail tube and enter the E. coli. After the life cycle is complete, the host cell bursts open and ejects the newly built viruses into the environment.
So you see how it works. So these phages are very specific viruses, and that they can either produce numerous copies, destroying the bacteria, but also they can also be expressed in a dormant stage, what we call lysonetic stage, and that can be expressed under specific circumstances. And we have, when we tried that test, at the beginning we were starting for a treatment, but due to all the difficulties we would be facing, we think we could use this bacteriophage as a diagnostic, and we did some validation and calibration studies showing a 90% sensitivity and 100% specificity, of course, after confirmatory sequencing. So the test itself, Tanya showed you the technique, and I don't want to go back to it. What we have now is 3 different primers, one from Borrelia sensulato, one from miyamotoi, another one for relapsing fever. And what is important is to have a triplicate each time and to have a confirmation by sequencing all the positive samples. And also what I would ask to say is not to go up to 35 cycles, because otherwise you got only fragments, and the fragments, if they're not confirmed by sequencing, they can lead to false positive results. We know that antibody-based tests are facing some difficulties and are not showing if the infection is still active. Lymphocyte transformation tests have been presented by Armin. They're providing an indirect evidence, and they can detect lymphocytes that have been in contact. They have a sensitivity, and I'm sure they are very good to monitor the treatment and the outcome. But there is a difficult identification, but now I see that there are some other specific TTLs. It also depends on the status of the immune system, and it cannot be performed during antibiotic treatment and even immunomodulating treatments, which are often the case in long-lasting stages of Borrelia infection. The phage chase is a kind of a direct evidence by an in vivo amplification, because either in the lytic or in the lysogenic stage, there are dozens of phage sequences. So, and these phage sequences circulate. They circulate, and so it's much more easier, statistically easier, to find them in a different matrices, like say blood, serum, urine, than for a direct detection of the bacterial DNA. There is no antibiotic interference, and it can distinguish Lyme from relapsing fever, Borrelia strains, and specific miyamotoi. Using that test, we conducted, together with Red Labs, a study on 2,200 samples coming from various European countries and from USA. And as a result, we had 34% of the tested samples which were negative, 60% negative, among them 64% of Borrelia miyamotoi and 25% of relapsing fever. I would like also to share some examples. In a case one, we had a male aged 70 who was living in Mexico. He had tick bites in 2015, no typical rash, and fatigue, loss of sight, fever, muscular pain, and what was much worrying for him, legs strength loss and urinating. You see that the tests performed in Mexico and the United States were all negative, whether they could be qPCR or ELISA, Western blot, they were all negative. And he got in contact with us. Babesia was also negative. He got in contact with us, and we were lucky enough to find that he was Borrelia miyamotoi positive. We had a treatment with ceftriaxone, doxycycline, and essential oils, the one which are based on Zhang's experience. And we had several courses of 14 days cures, and separated by 3-week pause. We performed normally these sequential treatments, and the improvements were obtained on brain fog, fever, muscle legs reduced, urinary fatigue remained, but it was a really appropriate diagnostics. Case 2 is a male aged 38 with a tick bite in 2016, no erythema migrans, symptoms was only fatigue, pains, and depression. ELISA and Western blot were negative, and the PCR phage test on blood was positive on miyamotoi. So we could give him also 2-day sequences of what we usually give for miyamotoi, cefuroxime, doxycycline, 3 weeks, and then a 3 weeks pause, and azithromycin every other day with doxycycline. And it was a very quick positive outcome, which is when we have this very specific diagnostic, I think we could have a good usage of drugs and not waste our time with useless other treatments that don't work on miyamotoi. Another case is a female aged 46 who lives in Europe, no tick bite memory, no erythema migrans, but since 2010 developed a stiff man syndrome in the back and with muscular and neurological pain in the left arm, no fever, but some chills. And that's why we searched for she had anti-GAD antibodies and Yersinia antibiotica, which was positive. So she was treated with antibiotics, but without any very good results. When we could perform, the miyamotoi also was positive in the PCR, and we conducted the same antibiotic as the case 1, and the improvements were very remarkable. She was now able to stand and get some steps, although stiffness remains, but the arm spasm stopped. So we are monitoring the treatment, and she's progressing little by little, although we must admit this is not quite resolved. In phage 4, a female aged 10, take part in 2010 with erythema migrans and ELISA and Western blot positive. She was treated, no symptoms until August 2019, and suddenly came back flu-like symptoms. And so she everybody was thinking, oh, this is the Borrelia coming back again, but she had Borrelia Burgdorferi and Miyamoto and relapsing feral were all negative with a phage PCR. So we didn't give any antibiotic treatment. And in fact, it was a kind of flu-like syndrome, and she was not treated and she recovered. So this is also another example of appropriate good usage of drug, no abusive usage of drug, that is permitted by this very specific and sensitive test that show that if there is a phage, there is an active infection. Another male age 8 tick bite in June 2020, no erythema migrans. The phage tests were tick Miyamoto positive in the ticks, but in the patient, in the urine, it was negative. So we decided not to give any treatment, and it recovered without any use of antibiotics. So altogether, this is a very good tool to monitor and to use the antibody. What are the questions we can ask to ourselves to this very higher incidence of Miyamoto in this large-scale study we performed? Maybe, as all these patients were late stage, Borrelia Miyamoto could have a better or a higher resistance to antibiotics, which are usually utilized. There may be also heat and climate factors. As we remarked that this in winter time, we had in our results a much higher percentage of Miyamoto that were present in the samples. And now that the hot season was coming, we assisted to the return, the comeback, if I could say so, of Borrelia sensu-lato, as well as relapsing fever. So maybe it's something which could be very interesting to see if there is heat and climate factors. We know also that bacteria exchange information via plasmids. And one could think that among this exchange of information, the Miyamoto type information could be more prominent, more effective in the conversation in a so-called conversation, that a dialogue that is between the bacteria, and that could explain the greater prevalence of Miyamoto type persistence. As a general conclusion, I would say that phages, being an evidence of bacterial activity, this technology is really an amplification system for active infection, and that allow the clinicians to evaluate the treatment and to discriminate between really post-Lyme syndrome and let's say long-lasting Lyme disease. We had conducted this, maybe the first large-scale report on prevalence of Miyamoto, and we could show the difference in the percentages. Results were permitted by this high sensitivity of the phage PCR test. We are now using this experience on phage-biased PCR to design another primers on Bartonella and on Rickettsia. Primers are ready. We are now testing them. The problem is that to get Bartonella patients is very difficult because they are not diagnosed by usual tests. And we try to have the one which have the very specific symptoms like adenopathies and stria on the skin, scratches on the skin, but it's still, we hope to have a number of sufficient number of cases to be allowed to show them in the very near future. The bibliography is there. So we have the patent, which is been made with Leicester University, and several authors which have been working on that. Of course, our gratitude goes towards the Patient Association and Red Laboratories, which is performing the test, because we were needing some very good technique for DNA extraction. And of course, Leicester University and Jean Yuchan, which is a PhD and fellow researcher, which is conducting the lab work and the primer design with us.